with us here Othmar Arnold, and he has been with the healthcare system of BC and Canada,
More Yukon.
Yukon, which is part of Canada for many years. And I want to know, what do you think about, in general terms, what do you think about the healthcare in BC more and Yukon, BC, Canada? What do you think in comparison with other countries?
Well, we do have a very well-organized treatment system.
Treatment system.
That's what I think we have. We have many levels of care, very good at diagnosing disease and then also treating it. And I mean, I've seen healthcare systems in third world settings that are not comparable in any means to what we have here, because they just don't have the same level of funding. And I think the Canadian and the BC system are very privileged in having quite a considerable funding base. And so there's nothing, I mean, there's always things that could be improved within that treatment system. And we can have better equipment and shorten wait times and so on. But however, what I see as one of the things is that despite of having one of the world's most efficient, best funded treatment systems, we also have no improvement in overall health status of the population. So we're spending billions of dollars on treating every disease known to man and science, and we're not seeing overall improvement of the health status of the people. And within the general population, there is pockets of people that are even further behind than others. I mean, let's look at Aboriginal people. Health is a well-documented fact that their health status is considerably lower than what the general population in Canada or BC is.
Is it because they're lacking enough doctors and healthcare workers?
I don't think so. There is hundreds and thousands of people in the field and services and this program, that program, the other program.
So what's the
I
reason?
think the lack is that, again, I emphasize the word treatment system.
Okay.
We're addressing the wrong problem.
Okay, we're treating good, but we're not preventing.
Yes.
Okay.
So we're spending 1% of our $1 billion health budget on prevention.
Only
And
1%.
99% on diagnosis and treatment.
Ah.
So, in 1974, Lalonde wrote the report, Health for All, something about the health promotion.
Marc Lalonde, you mean the
Marc Lalonde, yes.
minister of Pierre Trudeau's era.
Yes.
Okay.
Worldwide recognized as the initiator of primary health care, which means we have to take the healthcare closer to the people. We have to look at, not just disease and treatment. We have to look at, primary care, easy access points, more holistic view of health, not just medical problems, but look at where those medical problems originate. That why do poor people have more health problems than rich people, for instance. So we had a very good start made in Canada of addressing this need for primary health care. Eventually they got adopted by the UN as, the Charter of it was basically adopted by the UN, and I don't recall off the top of my head what the exact name was. And then, if we look back, so that's 40 years of history that this document has been drafted and adopted. And there's one single country in this world who actually shaped their healthcare system according to the principles of primary healthcare. And it hasn't been Canada.
Which country is that?
Well, it's Cuba.
Oh, but they probably had it already.
Well, Cuba had, basically after the revolution, not much of a healthcare system, but the whole political will was there to say, wow, this document that came out of Canada, this idea of primary healthcare and health promotion, is quite something.
Yeah.
This is the right way to do healthcare, and they eventually built up their entire healthcare system according to the principle of primary healthcare, while any other country in the world, including Canada and BC, has stuck with a hospital-based, doctor-driven healthcare system.
Mm-hmm.
That's very good, again, at diagnosing and treating specific disease, but they're not really increasing the health of the people.
So you're saying that Canada proposed this to the United Nations, and the only country that actually put in practice was Cuba, and not even Canada. Canada did not make any changes at that time?
Well, Canada did make changes. I mean, if you go to nursing school, you talk about primary health care, you talk about health promotion. Mm-hmm. And yes, we do have in each doctor's office a couple pamphlets about health promotion. But if you look at the health insurance, and if you want to, for instance, do something proactively, then very quickly you'll realize that this is not being covered by your health insurance. For instance, general screening, health screening on a regular basis, well, that's out of pocket because it's not valued by our health insurance system, which is part of the overall health care, as they're only paying for diagnosis and treatment of medical disease. Right. So there's, in that way, yes, we talk about primary health care. We have a similar system implemented in very rural and First Nations Aboriginal communities, where we have a health center, we have nurse practitioners or advanced practice nurses working there as a single point entry to the healthcare system. But again, the focus is on diagnosis and treatment and not so much about prevention and health promotion. It's against that 1-2% of the budget allocated to the important stuff, and 98% of the budget allocated to the stuff that we're good at.
And then the healthcare administrators probably say, if we are going to shift some more resources to prevention, where is it going to come from? We're going to have to take it from operating, from hospitals, from other segments. Do you think that the budget, which apparently is about 41% of the total income for the government, do you think that is not enough, or should we increase that budget, and who should do it?
Well, if we just shift budget lines, I don't think the change will ever occur, because there is significant economic interest in having the health insurance the way it is, having the hospital system the way it is, the pharmaceutical industry. There's big interests behind that.
You mean private, for-profit interests, for-profit
There
companies?
is that. I mean, doctors make money with sick people, not with healthy people, and they can not bill for keeping people healthy. They have to bill when people are sick. Okay. So these are not just. It's not just greed. It's the whole idea how the system is set up, the fee structure, the pay structure, and the whole medical knowledge is not conducive to producing health. It's the medical knowledge is there to diagnose disease and treat disease, but one disease at a time. So let's look at diabetes. a big expense these days. And yes, we read in the paper, so many people will eventually have diabetes, and it'll cost our system, and it will be unaffordable to our system to have all these people. But we have all the treatment options for diabetes. But nobody looks at, okay, so diabetes, yes, it's a disease. We know it has to do with insulin, it has to do with carbohydrates and all that stuff, and we can send out some public health messages about sugar and salt and exercise and all that stuff. But we also could look at the numbers of where the highest proportion of diabetes occurs. And well, it has been labeled as a First Nations disease, and research went into high gear looking at some genetic defects in First Nations populations that would make them more prone to diabetes. But what about the black people in the United States? They have the same percentage of higher occurrence of diabetes as First Nations in Canada. There's no genetic link. So there is another link. And if you look at the income distribution, all of a sudden you see the link. So it's economic disadvantage. That's the link between the general population incidence and the First Nations or Black American populations. But the medical system is not funded or structured or even enabled to look at these causes and treat them. So we'll end up just using insulin and pharmaceuticals and try to get people to exercise more and so on.
So you're saying that the determinants of health are, one of those factors is the economic factor. So economic inequality is actually causing some diseases, and we're not looking at those factors, and we're thinking that it's a race cause because you're of certain race, when in fact it has to do with economic.
Well, we are looking at these things, but not in the context of healthcare. And we're not putting the resources or even the emphasis that this could be like poverty reduction and elimination could decrease the healthcare budget by 10%. Not because we're curing any disease, because we're decreasing the economic inequality of the people. So we're not very good at recognizing all these other factors. I would, from my personal observation, also even like to mention like spiritual factors. Why are people